everyone. So today my skills video is going to be on chest tubes. So what exactly is a chest tube? A chest tube is a tube that is inserted into the pleural space of the lung to remove air or fluid to help the lung re-expand. Or it can be a tube that is inserted into the mediastinum space, which is right underneath the sternum, to drain fluid from around the heart after cardiac surgery to prevent cardiac tamponade. So the lung is surrounded by the visceral pleura. Then there's the space called the pleural space, and then the parietal pleura surrounds this space and is attached to the thoracic cavity. When lung expansion occurs, the visceral pleura and the parietal pleura glide against each other because there's a small amount of serous fluid in that pleural space that allow them to do this during lung expansion. So this gliding motion creates negative pressure, which allows for proper respirations. So if air or fluid gets caught in this pleural space, that negative pressure is altered and it can cause the lung to collapse. So a chest tube is necessary to remove this excess air or fluid and restore function of the lungs. So what would cause a patient to need a chest tube? The patient could have a pneumothorax, which is air in the pleural space. They could have a pleural effusion, which is fluid in the pleural space. They could have a hemothorax, which would be blood in the pleural space. They can have an emphysema, which is infection in the pleural space, or like we talked about, they could have cardiac surgery and they would need that mediastinum space tube. So you have two types of suction. You have a wet suction and a dry suction. The wet suction is the one that I will be showing you guys today myself, and then the dry suction I have a picture of that I will do a voiceover of so that you can understand the differences and just have a visual of how the two differ. Here we have a wet suction container. So as you can see, you have a lot of tubes up here. So this tube is the one that connects to your wall suction, and this tube is the one that connects to the patient. This is what the end of it looks like. So this little white capped thing right here is where you will fill your water in the suction control, which I will talk about in a second. So your first chamber over here would be your collection chamber in white. So this is where the substance will go as you're removing it from the patient. Then you have your water seal chamber right here in red, and this water will move up and down as the patient inhales and exhales. And then at the bottom of this is the air leak monitor area. So if you see bubbling in this area right here, it's bad. It could mean that there's an air leak somewhere in the tubing or in the system. So then you have the suction control chamber in blue over here. So suction is regulated by the height of the water in the suction control chamber when connected to wall suction. So basically the doctor will give you an order for how much water to put in this part, and then you will fill it up, say to 20 usually. So you will hear and see gentle bubbling in this area while it's working, so don't freak out because this is absolutely normal. So water can evaporate in this chamber, unfortunately, so it is very important to constantly monitor this and make sure that it's staying at the level that is prescribed. Unfortunately, I did not have a dry suction container to show you guys myself, so I pulled up a picture of one and I circled some things that I wanted to point out. So as you can see on first glance, it looks a lot similar to your wet suction. You have your collection chamber on the right circled in purple, your patient connector on the bottom circled in blue, and your suction port on the top circled in yellow. So you also have a water seal chamber, just like your wet suction. The main difference in these two types of suction is how the suction is controlled. So this suction and the dry suction is controlled by a suction monitor bellow circled in red, and this balances the wall suction. You can adjust the water suction pressure using the suction control regulator circled in green, and with this you also have an air leak monitor on the bottom, just like your wet suction, circled in orange, and if you see bubbling in this area, that could signify that you have an air leak. With dry suction, you also have higher suction pressure options, and there's no bubbling and no evaporation, so you don't have to keep refilling that chamber with water, and it's also a lot quieter because there's no bubbling in the suction control chamber. So this is going to be my patient for the day, and he has a chest tube that is connected to wet suction. So he has an occlusive airtight dressing right here to prevent air leaks. And so to manage his tubing system, you want to make sure that the drainage system stays below his chest. So as you can see, my drainage system is right here. I have it propped up on this little stand that is attached to the bottom. So normally it would be turned in like so, but you can pop it out and it'll easily stand on the floor. You also want to ensure that your tubing is free of kinking and clots. So you just go along the tubing like so. Do not strip it, but just look at it and make sure there's freely flowing fluid coming out of the patient. And you also want to ensure that your connections are sealed. So we have an airtight dressing, so we're good to go. We could check the drainage system and make sure that the tubing is connected safely to that as well. So you also want to monitor your drainage system. So with this, you're going to look at your collection chamber, and you're going to look at the amount and the color that the patient is putting out, because it's likely that the physician will ask you for this. So check it quite regularly and keep track of what they're putting out and what it looks like. So the water cell chamber here in red allows air to be removed from the pleural space without air being allowed to enter the body because of negative pressure. So the water level increases during inspiration and decreases during expiration, but it's the opposite if the patient is on positive pressure mechanical ventilation. So if they're on mechanical ventilation, the water will increase during expiration and decrease during inspiration. If the water does not fluctuate at all, the lung may have re-expanded, or there could be a kink somewhere in the tubing, so it's important that you check for that. So we briefly discussed earlier that if there's bubbling in your air leak monitor, which is this section right here, then that could mean that you have an air leak somewhere in your tubing. However, if your patient has a pneumothorax, intermittent bubbling in this area may be normal. So it's very important that you know your patient history for this reason. Also, the suction control chamber, in wet suction, you're going to hear loud bubbling. And as I said, it can evaporate. So you're going to have to fill it with sterile water through this right here, this yellow part. It just pops off, and you just dump the water in here at the prescribed level. And then dry suctioning, there's no water column, and it's regulated by the monitor bellow that you saw in the picture from earlier. You will also want to monitor their lung sounds and their respiratory rate. Ask the patient if they're experiencing any dyspnea. You also want to check the insertion site for infection, which is why most of the time you have a see-through dressing such as Tegaderm. You also want to check for crepitus, which is basically when CO2 gets trapped into the tissues. It causes this like crackling sensation upon palpation, so you want to check for that as well. Have the patient cough and deep breathe, and reposition them as well to help promote lung function and move that fluid around. In terms of things that could go wrong with chest tubes, you want to know what to do if the chest tube becomes dislodged, or if you knock the system over, or anything like that. So if the chest tube becomes dislodged, you will want to cover the site with a sterile dressing and tape it on 3 sides to allow air to escape so they don't get a tension pneumothorax, and notify the physician immediately. So, and if the system breaks, or if it falls over, like if you accidentally kick it over because it is on the floor, you want to get a new one. You don't want to keep using that same system. And while you're waiting on a new one, you want to take the tubing and insert it into 1 inch of sterile water to create that water seal and keep that pressure where it's supposed to be. So you do not want to milk or strip this tubing, which is when you basically do like this to try to get the clots out or anything that might be in there. This can increase the pressure in the system to a point where you don't want it to be. So always check your protocol about this. And then clamping could also cause a tension pneumothorax. So follow your hospital policy and never clamp if you don't have a physician's order to do so. I'm also going to discuss the removal of a chest tube because you may be asked to assist in the removal of one. So it can be done at bedside, and the first thing you need to do is get your supplies. So you need to grab sterile gloves, dressing supplies, mask, goggles, suture removal, and a rubber-tipped hemostat. Also teach the patient the Valsalva maneuver, which is when you deep breathe and exhale and bear down during the removal of this. So this prevents air from entering the pleural space during the removal as that tube's being pulled out. You want to also position them in a semi-Fowler's position and pre-medicate them, because it can, I imagine, be very painful for them getting a tube pulled out of their pleural space. So, and also during this process, you want to monitor their respiratory status, their lung sounds, any drainage that is occurring, see their chest rising, ask them if they're feeling any dyspnea. And then after the removal of the tube, you want to send them to get a chest x-ray to get an update on how the lung is looking. So I hope you guys learned a lot during this video, and feel free to ask me any questions if you have them.